So I want to thank the organizers, Sanjay, and everybody who has done so much effort to make this happen. And I'm going to go straight into this. These are my disclosures. I unfortunately don't have any stock in any of those, so that's why I work so hard. As I'd like to say, this is where Gainesville is up there. So whenever you come and visit Orlando and Disney World, just come, drive a couple of hours and come and visit me. I promise I will not do a liver biopsy on you. This is our university. These are our three different hospitals. This is the Veterans Hospital that takes care of about 130,000 veterans. That's a population that's older and more chronic disease. This is our research unit where we do a number of different studies. So the TCDs have been a very complex kind of compounds. They were available since the year 2000. There's a lot of confusion, misinformation, and still some people think that Avandia increases cardiovascular disease. The FDA said that probably they don't when they reviewed all the data in 2014, but Pioglitazone clearly reduces cardiovascular disease. So because this is not very easy to memorize, what I decided is that you're going to remember 3 good things that they do, and the 3 are bad things that you want to monitor and be aware in your patients. So number 1, the beneficial effects are on the liver, where there's resolution of NASH. You don't have any more of that inflammation. And this typically is associated with no progression or even some improvement in fibrosis. There is prevention of cardiovascular disease. And these are 2 intravascular ultrasound studies that showed that if you took a sulfonylurea or took pioglitazone, you have progression with sulfonylureas, but not with TZD or in this case, pioglitazone. And we're going to touch on trials that showed reduction in cardiovascular events. And it's probably the best medication to prevent the progression to type 2 diabetes. Now, on the other side, there are undesirable side effects. We're going to talk about weight gain and edema, typically dose dependent. And what I would like you to leave is to tell you which are the patients you should not put on pioglitazone. There's always a debate about bladder cancer, and we'll talk a little bit about that. And osteoporosis probably is the main issue that I see in the long term. So let's get started with the liver. This is one complication that we should incorporate when we talk about obesity. Again, it's the #1 cause of liver transplantation in people age 20 to 40. She's 19 and has cirrhosis from NASH, and I see that all the time. So that's why we wrote a review about a couple of years ago in which it's very simple that if you just use liver enzymes, you're going to miss most people that have a fatty liver. So there are other methods to do this. Typically, liver ultrasound is what we have, or this other technique that comes with a FibroScan. The other thing you can see is patients with type 2 diabetes, the majority have a fatty liver. So the fat in the liver is just your tip of the iceberg to try to identify fibrosis. So this year, the ADA, for the first time, came up with the guideline that if you identify fatty liver or elevated liver enzymes, you should look for liver fibrosis. And this is the same analogy for nephropathy. We didn't have any nephropathy until we began doing microalbumin measurements, and we didn't have osteoporosis until we began doing bone densitometers. So this is how the liver looks like. This is a normal liver. This is the liver of about 30 to 40% of your patients. Okay, you see that there's this globular inflammation called macrovesicular steatosis. You see this hepatocyte that's very different than these. This is an hepatocyte that is ballooning, it's swelling, and it's dying from apoptosis. This is that measure of disease activity, and then you have all this inflammation. Notice where you have inflammation, you're going to have more of this blue stuff that is fibrosis. And about half of the patients don't have elevated liver enzymes. So this is something that's very pervasive, doesn't give usually any symptoms, and you're only going to discover it when they come with cirrhosis. How to diagnose it is something complicated because we don't have any great tests. We just mentioned a few tips recently, but I'm going to talk a little bit more about that maybe tomorrow at 10:15. Now, what happens is that in obesity and diabetes, you have the perfect storm for your liver to store or to make new fat, because you have a lot of fatty acids going to the liver. The liver has only a limited capacity to secrete excess triglycerides, and if not, it's going to probably cause mitochondrial dysfunction. You have high insulin and glucose driving de novo lipogenesis. Now, all of this doesn't tell you why you develop NASH, because you can have two individuals with the same amount of fat or BMI. One has NASH and the other one doesn't have, and we call NASH the inflammation. And then another one will have a lot of fibrosis or cirrhosis while the other doesn't. So we don't understand this biology. But what we do know is that the more obese, the worse your diabetes is, and the long-standing diabetes is a factor. Now, the other thing that's important from the big picture is what can we do to turn this around? So what pioglitazone does, it turns off all these steps, because you begin transforming your adipose tissue, and that adipose tissue of a lean person. So you hold on to your triglycerides, your insulin and glucose goes down, you have less triglycerides. When you take pioglitazone, your triglycerides drop about 60%, and you also decrease probably pressure on your mitochondria, and that's why inflammation gets better in most patients. You also happen to lower triglycerides by probably decreasing the load of fat in your liver. So that's why in the current guidelines, pioglitazone is the drug that has been promoted to be used the most. And this comes from these studies. This was our first study in diabetics or pre-diabetics. These were non-diabetics. Then we did a 3-year study in individuals with pre-diabetes. And basically, this is what you're going to get. Every time you start somebody with pioglitazone, liver enzymes go down, which doesn't mean that everybody's going to get better, but about half to 2/3 get better at the level of the liver. And as long as you take it, your liver enzymes remain low. Once you stop it, liver enzymes go back up. And we suspect that you just get the disease again. So if you look at things, this primary endpoint is a little bit complicated, but look at resolution of NASH. This means a pathologist looked at this and says, you don't have any more inflammation. And that improves in almost 60% of the patients. And then when we looked at those who had the worst NASH, it improved about 2 out of 3 patients. So this is something that works. We used 45 milligrams, but because we wanted to use the max dose. But in general, we use in the clinic, we start with 15 milligrams, bump it up to 30 milligrams, and usually keep it at that level to try to minimize weight gain. Now we have this new study that is in press in which we said, well, vitamin E works in non-diabetics. Let's see if we add vitamin E plus pioglitazone, if there's any benefit. So we identified 288 patients in whom we, in the end, randomized 105 to 3 groups, placebo of both drugs, vitamin E or placebo of pioglitazone, or both drugs together. And these are the main results. Again, this little bit cumbersome endpoint, but concentrate on resolution of NASH. You don't have NASH at the end of the study. So vitamin E didn't do a whole lot. This was a borderline benefit that happened in 1/3 of patients compared to 12%. But pioglitazone, again, when you add it, worked similar to the other. So there's not an additive effect, but again, it just shows that the drug consistently works when we use it. So we're going to shift gears a little bit because most of your patients are going to die of cardiovascular disease. So let's see what pioglitazone can do for cardiovascular disease. Again, we're not going to talk about these 2 studies. We're going to focus on PROACTIVE and IRIS. Again, NASH in the setting of diabetes and obesity is a perfect storm. And what pioglitazone does, it really works basically on each of those levels. Now, once you have liver fat, it's likely you're going to have fat in your heart, and this is being associated with diastolic dysfunction. About 20 to 30% of your patients has some degree of diastolic dysfunction, and this has been even worse in patients that have fatty liver. So this is a large study in 280,000 patients in which patients that have NAFLD typically have a 2-fold chance of having diastolic dysfunction. So this is important because if you have somebody who's very obese, long-standing diabetes. You need to think about this, because if they have diastolic dysfunction and they retain fluid, they're going to get what we say pioglitazone giving you heart failure. It's not giving you heart failure, it's just unmasking your heart failure. Again, so pioglitazone improves every one of these aspects, and we're not going to have time to do much about it, but it's been known forever, and there are like 4 or 5 studies from the early 2000s that show that pioglitazone improves myocardial function. There's a recent study from the group of Dr. DeFronzo in San Antonio showing the same thing. It's very important that you live with the concept that pioglitazone, if anything, improves cardiac dysfunction, but it's going to unmask your diastolic dysfunction if you have edema. So let's talk a little bit now about proactive, just 2 slides. This is the study. It didn't meet the primary endpoint because they included an endpoint called revascularization, which is very variable. But if you looked at cardiovascular death, stroke, and MI, it did have some benefit. And when you broke it down between recurrent or non-fatal stroke, the differences were fairly large, same as for recurrent or non-fatal MI. Now, this is not the large kind of prospective studies that we're doing with pre-specified endpoints now, but I was very interested in what happens in a more severe and sick population, so I looked at this landmark study by Dr. Fonseca and studying veterans, and you see that when you look at the patients that have typically long-standing diabetes, the rate of heart failure is pretty high. It's like 29%. But when you account for all the traditional risk factors, smoking, obesity, hypertension, patients who use TZDs don't have higher rates of heart failure. So then I looked at additional studies, and I'll show you that in a moment. It's very important to know that TZDs in general are going to have an effect to improve to some extent your cardiovascular risk. The best study since proactive is the IRIS study. The IRIS study, they took 3,867 patients without diabetes, but who had an ischemic stroke or a transient ischemic attack and followed them for 5 years. And what they showed is that those on pioglitazone had a reduction in cardiovascular events. And the key thing is that not only they had that, but they looked really at all the different endpoints that were related to this. One of the endpoints was acute coronary syndromes, and pioglitazone reduced this risk by about 29%. So again, this is how you see the curves. Now, what they concluded is that perhaps if you have a stroke or a TIA, pioglitazone could work in the same way as an aspirin or statins to try to prevent your next event. They have done another study, another analysis that they just published. This is 3 months old, in which what they did, they realized that let's see what happens if we look at those who took 80% of their prescribed medication, because medications work a lot better if you take them, right? So what they did, they looked at those who had taken them at least 80% of the time. Look at the reduction in stroke, about a third, stroke and MI, acute coronary syndromes, again, the composite of all of these, and new onset diabetes. This is pretty consistent with the ACT now. And again, if you put everybody who took it or did not take it, it got diluted some, but again, still significant. So this was just published recently, and most of you don't read JAMA Neurology, nor do I, but somebody brought it to my attention. This is information that's useful for you. So again, it's a useful approach for secondary prevention. And again, studies with stroke have also looked at this. In the IRIS study, what they looked at is that the population that really benefited were those with ischemic strokes. And this was from early on. It did not have any effect on hemorrhagic events. So this is something to keep in mind. Okay, the last thing to remember is prevention of type 2 diabetes. So again, we know that you're going to get diabetes when your beta cells cannot keep up with your degree of insulin resistance. And again, fatty liver plays a big role into this, because this is a prospective study that looked at people without steatosis, people who didn't have steatosis in a follow-up. This is 13,000 patients, followed for up to 7 years in a database in, I think, Taiwan or South Korea. And when you have new development of fatty liver, your rate of diabetes doubles. Now, if you had fatty liver at baseline and you don't get much better, you have a 4-fold increase. But if you have worse fatty liver over time, this probably puts chronic pressure on your beta cells and your rate of diabetes increases several-fold. So this is something really important. The other thing that I know all of you are aware is in the ACT NOW, patients who took pioglitazone and had prediabetes had a 70% or greater reduction of diabetes. So this is probably the most effective drug to prevent diabetes, and most likely it is because you're removing fat from the liver and allowing a break on your beta cells to catch up with the degree of insulin resistance. And again, most of you remember that metformin only works in young individuals, not in older individuals, from the data from the DPP-4, from the Diabetes Prevention Program. But in this study, the ACT NOW, pioglitazone worked equally well in these are younger adults who were on placebo. These are the younger adults who took pioglitazone. Older individuals defined as 61 and greater. These are the ones on placebo. You see that there is a benefit no matter what the age. So it's a drug that can be easily used for many of your patients above age 65. And again, what they noticed is that those who don't have recurrence of disease are those who can remain with normal glucose tolerance, okay? So that's another thing that tells you that how pioglitazone works is probably improving insulin secretion. Okay, so that's the good part. Let's see what the bad news are and how you need to choose your patients optimally to not give it to anybody. So let's talk about weight gain. Typically, weight gain is dose dependent. If you use 15 milligrams, there's minimum weight gain. You use 45, you're going to have more weight gain. So again, what the typical target, I think, of TZDs is adipose tissue. There are 10 times more PPAR gamma receptors in adipose tissue than any other. And what you're doing, you're just changing the biology of fat to make it like the fat of a lean person. My choice would be that you lose weight and become lean. But if you don't succeed at that, what Pio does, it makes it that of a fat of a lean individual. So now your insulin levels go down, your fatty acids are not chronically released, harming your muscles, causing more insulin resistance all over the place. And this is the best proof. There are many, many studies. The best proof in patients with fatty liver is here. In the study that we did, this is 18 months compared to placebo. Diet improved liver fat a little bit, but when you take pioglitazone, there's a 60% reduction in liver fat. And this is hepatic insulin sensitivity. This would be a control without fatty liver. Once you take pioglitazone, it gets near the level of somebody without a fatty liver. Muscle insulin sensitivity improves, and your adipose tissue becomes pretty much like someone without a fatty liver. So basically, you're changing the biology of your patients. And I put this slide, which I put in a grant to study 15 milligrams. These are 4 studies that have looked at 15 milligrams of pioglitazone. This is 15 or 30, 15, 30. If you look at the effect on glucose, it's pretty comparable between 15 and 30. This is a small study in just a handful of people. But in the other studies, the reduction in A1C is similar whether you are on 15 milligrams or 30 milligrams. You typically have a similar reduction in triglycerides, an increase in HDL, and the weight with the 15 milligram dose is basically unchanged. So this is an option for many of you who are not familiar with using pioglitazone. You can start at 15, see what response you get. The patient is doing well. You may feel comfortable to titrate to 30. Now, the other area of weight gain is edema. So some of your patients say develop this heart failure. Again, the concept is that you're unmasking diastolic dysfunction, and there have been many, many studies that have not seen an increase in heart failure. Okay, we don't have a lot of time, but in the study that I show you, the IRIS study, the rate of heart failure was 4% with pioglitazone and 4.2% on placebo. So all of these studies have not seen this increase in heart failure with pioglitazone. What is the story with bladder cancer? Well, with bladder cancer, most studies have been negative. And again, in the 5 positive studies, again, the rate of bladder cancer is very low. You need to treat between 877 to 4,500 patients for 3 years with 30 or 45 milligrams if it's true that you induce 1 case of bladder cancer. And the study that really started was this diabetes care paper that in the 5 years saw this 20% increase in rate, but then their 10-year data saw less of an effect. So if you have a drug that's inducing cancer, over time, it should go up, the rate of cancer. But in this case, it didn't. So the authors concluded here that basically they could not tell that there was really a close link. But again, we'll really never know. So what I typically do, I always do a urinalysis, make sure your patient doesn't have hematuria, and definitely would not give it with anybody who has a family history of bladder cancer. And again, people have looked at other cancers with pioglitazone, and in general, colorectal, lung, breast, prostate, they all are either neutral or show a little bit of a benefit. Very good. Final issue is osteoporosis, okay? So this is probably the greatest problem with TZD. The bone has been a big issue, and again, I would not use a TZD in somebody who's younger than age probably 25 or 30, because still in the 20s you're accruing bone, so you got to be careful with that. And this has been the effect on lumbar spine. Let me see. So this is lumbar spine. Again, these are studies with rosiglitazone also. It probably is a class effect. They're all showing a greater effect, a negative effect on bone. This is on the femoral neck, also some effect. I think the best single study, again, is the IRIS study. In this study, before we tended to think that this was more in females, IRIS study clearly documents it's in both males and females. So this is in this study in 3,800 patients. You see with pioglitazone, there is a greater number of patients that have a fracture. In women, it also happens, but after a little bit later. The bottom line is that by 5 years, the risk of fractures is higher. And this is a population, remember, that had a transient ischemic attack or that had a cerebrovascular event. So most of these fractures have been related to fall, and this is an older population that had greater propensity to fractures. But still, it is an effect that is a real effect. So in the end, I mean, the key thing is considering probably pioglitazone the best drug to address the epidemic of NASH. By addressing the epidemic of NASH, probably you have a potential to preserve beta cell function, preserve the optimal glycemic control long term. And I want to show you some information that's really important, because if you are able to modify adipose tissue, then you're going to release the pressure on the liver to become insulin resistant, and you are not only going to decrease fat in the liver, but you also decrease the activity of the stellate cells that lay collagen and that cause fibrosis. And to make the point, this is a summary of studies with TZDs that have lasted more than a year, typically more than 2 years. And you see that the durability of effect is pretty consistent. Of course, there's weight gain, but it's less than weight gain with insulin, at least. If you compare this to the durability of sulfonylureas, you take a sulfonylurea, your sugars drop acutely, but again, by the second year, you're pretty much where you were before. And again, most people forget that you also gain weight with sulfonylureas. Very good. So with this, I think we're going to, I want to leave you with my personal experience of how you should be using pioglitazone. Number one, it has effects well beyond glycemia, on NASH, on cardiovascular disease, and on prediabetes. I think that people who have a BMI greater than 40 are poor candidates because although they may receive metabolic benefit, if they stop it, they are stuck with additional fat. In addition, many of these patients tend to have already edema. So this is a problem. So look at their feet. If they have edema at baseline, not a great choice. And I've seen that many in the VA, we have many patients on amlodipine that typically also is associated with edema. So I try to either stop or reduce the amlodipine, or I don't combine it usually with pioglitazone. Long-standing diabetes or high doses of insulin are another group that typically is going to be associated with more weight gain and edema. And if you suspect heart failure, do a workup before you commit them to pioglitazone. And if you can, then just start 15 milligrams. Typically 15 milligrams is not going to be associated with significant side effects. Osteoporosis is probably the single most important factor to keep in mind. If you have a postmenopausal woman with osteoporosis, this pioglitazone would be a bad choice. We have published our own data on this, and there's really minimal, if any, weight loss, but in larger groups, this is an issue. So you need to keep this in mind. If you're not sure of how to use pio, start 15 milligrams and see how things evolve. And again, follow the patients. Again, you're going to notice ALT going down, A1C improving. And again, if things are going well, like what happened in most of your patients, I typically would increase it on the next visit to 30 milligrams. And again, check on your visit. Start your exam by your feet, which is always a good thing in patients with type 2 diabetes. Make sure they don't have edema. And again, also there's some equivalence for diastolic dysfunction, people feeling tired or with no energy. That could be an indicator of heart failure. So again, in looking at the guidelines that you're now very familiar with, currently we have the TZDs as a choice to avoid hypoglycemia. Typically in the absence of using sulfonylureas or insulin, they don't cause hypoglycemia because they just improve your insulin sensitivity. They're also in the low-cost bracket. In the United States, in the VA, it costs 8 cents a tablet. In regular stores, it's $5 to $10 a month. But what I think is missing from this guideline is patients with NASH and fibrosis, because these are the patients that will have increased mortality and greater risk of cirrhosis. So with that, I just want to thank those who helped me do all the hard work. We have a very vibrant group in Gainesville and Florida. So we have about a minute and a half to make some questions. So thank you for your attention.
So